My name's Tom Quick. I'm a nerve surgeon at the Royal National Orthopaedic Hospital. My job really is to deal with people who've had injury to their nerves. I also have a research interest linked with the scientists in UCL and interact with a number of the tissue engineers and cellular engineers and biologists in terms of improving outcomes from nerve injury. So patients who've had their nerves injured can have problems from a number of reasons. One of the most striking is that the limb doesn't move, paralysis. They also have problems with pain. They also have problems with sweating and the quality of the skin and feeling and sensation. The emphasis on diagnosis really hasn't changed for almost 100 years now. In most other medical areas we have very impressive scans and technology to assess. The majority of the emphasis in nerve injury assessment is clinical. The imaging technologies that we have, MRI scan and ultrasound, are useful to some extent, but don't often add much to that diagnosis. So what we're trying to find now is ability to see those tiny nerves, see the changes of the nerve, rather than just using ultrasound or MRI scan to look for associated signs. So we might look, for example, for a hematoma, for a swelling or a bleed around the injury, but we can't often see the nerves themselves. So when a nerve is injured, there's a number of potential ways to treat that. Oftentimes it's just relieving the scar around the nerve and allowing that nerve then to regenerate. But many times the nerve's been damaged so badly and the structures inside so badly damaged that it's not going to naturally regrow. So then we have to have a number of options, but we can cut out the damaged segment. And if the parts of the nerve are still able to then come together without any tension, then we can sew those together with very small microsurgery and then allow the nerve to regenerate and to regrow. These nerves, the axons, the nerve cells, grow very slowly. And often there's a long distance for them to travel. If I had an injury in my neck and the nerve had to travel all the way to my hand, that can take a year. And oftentimes the muscles just don't wait that long. So by the time the nerve gets there, the muscle has already died away and atrophied. So it would be lovely to be able to get those axons to the targets faster, or perhaps to tell the target, the muscle that's waiting, just to wait that bit longer before the nerve arrives. With most medical conditions, there's a drug that you can take to improve things. Unfortunately, in nerve injury, there isn't. There is nothing that we can do to manipulate that regeneration. We've been focused on developing novel drug therapies and taking them from the lab into the clinic with a number of experts investigating exactly how we can synthesize drugs to change cells and make differences also to patients' improvements. We also have a group investigating developing artificial tissue solutions to those specific clinical problems. Medical imaging is another area where we could have great opportunities to make changes and improvements. We don't have an ability to see the growth and the regeneration of nerves. If we could see that, we'd have an awful lot more information how to make timing changes and decisions about treatment. The unique aspect of the Centre for Nerve Engineering is really bringing the clinical expertise and the UCL experts. We have a number of ongoing projects, particularly in medical imaging, where we're now able to look both in animal models and some human tissue and also computational models at the regrowth of nerves, looking at the volume of these regenerating nerves and how they start to move forward.